Just a second, Mike. We're just setting up the live stream at YouTube. So, good afternoon, everyone. First of all, I'd like to thank everyone who joined us today at our hematology grand rounds. It gives me great pleasure to introduce today's guest, Professor Michael Rauh. Professor Rauh is an assistant professor in the Department of Pathology and Molecular Medicine at Queen's University, Canada. He's the head of the Rauh lab, whose research focus is mainly on myeloid neoplasms, particularly translational myeloid cancer pathology and the immune environment of these diseases. I had the pleasure of meeting Professor Rauh during my PhD a few years ago. His knowledge and skills in these areas fostered the collaboration between us, which helped me and taught me a lot, and for which I'm very grateful. He will talk today to us about clonal hematopoiesis of indeterminate potential, recently described phenomenon with several important implications to both hematological and non-hematological disease. Thank you very much, Michael. It's a pleasure to have you.
Likewise, it's an extreme pleasure. Hola, hello everyone from Canada, from Kingston, Ontario, Canada. I look forward to participating around. It's a real pleasure and an honor to have this invitation. And I am collaborating with Dr. Duarte and Ozello, and also a group at the University of Ceará in Fortaleza, so Dr. Magalhães, Dr. Pinheiro, and some of their trainees. And so I would like to also highlight some of the collaborative work that we're doing and the directions that we're taking between Canadian and Brazilian researchers. So I've been to your country one time previously, your lovely country. It was absolutely beautiful. It was around the Hemo 2017 meeting in Curitiba, and had a chance to meet Margaret in person there. She had established previously some connections with Dr. David Lillicrap, who's a world-renowned hemostasis researcher in our department previously. And so thankfully I was introduced to Margaret, and then Bruno and Gabriella, and then later Sylvia and Ronald and all of their labs and their research. So I look forward to returning to your country one day. Unfortunately, now we find ourselves in these times, and so it's a pleasure to contribute in a virtual setting. Since I'm projecting now, I can't see if there's any questions. I would welcome any questions you have during my presentation. That's perfectly fine. If someone notices something in the chat, for example, you let me know, or we could wait. Hopefully there'll be plenty of time at the end to discuss your questions and your ideas. These are my objectives for today. I would like to describe the phenomenon called clonal hematopoiesis and its origins. It's also called, so you'll see it called CH or CHIP or ARCH for age-related clonal hematopoiesis or clonal hematopoiesis of indeterminate potential. And I'll discuss a little bit about those definitions. The CHIP or CH, as I'll mostly shorten it now, impacts hematological malignancy risk. So I'll talk about that. Also, something that has been very interesting is that these mutant blood cells also influence non-hematological diseases, especially of the cardiovascular system, were some of the original ones discovered, but the list is expanding, and I'd like to talk about that and understand where it's a combined rounds. There may be some internists here as well, in addition to those focused on hematology. And so clonal hematopoiesis seems to touch on a lot of aspects of internal medicine. Finally, I'd like to close with something more provocative and to consider the rewards and the risks of surveillance for these pre-leukemic clones and the potential for intervening earlier in the course of malignancy than we do now. And CHIP is a paradigm for other processes in other tissues where mutations are accumulating with aging, and I'll just very briefly mention that as well. So my journey to clonal hematopoiesis began with studying myelodysplastic syndromes. As you're probably aware, these are clonal disorders where the bone marrow fails. The bone marrow is ineffective at producing blood cells, and peripherally there are cytopenias. And people with MDS have a propensity to transform to leukemia. Now, as a pathologist, we're focused on the diagnosis, And this requires, in addition to unexplained cytopenias, the recognition of dysplasia at a certain threshold here, greater than or equal to 10%, in at least one myeloid lineage. Diagnosis can be facilitated by an increase of blasts, the most primitive cells in the marrow, so somewhere between the 5 to 19%. Once we cross, obviously, the 20% threshold, that's acute leukemia. It can be helpful if there are cytogenetic abnormalities as well. We put those together in the diagnosis. I won't go into detail about these, but these are some examples on the right of dysplastic features of the erythroid lineage in the top two panels, with nuclear irregularities, including ring sideroblasts where iron is trapped inside mitochondria around red cell nuclei. Megakaryocytes, the precursor for platelets, can have unusual features. And in the granulocytic lineage, in particular, the neutrophils, they can have hypolobated nuclei, where normally there should be 3 or 4 nice lobes. These ones have 2, and their cytoplasm can be lacking the typical granulation. Although these are meant to be objective criteria that we apply, the challenge is that there's poor inter-observer variation. And also there are reversible secondary causes of dysplasia, mimics or imposters that are out there. And so we have to be very careful, especially in the early stages of MDS, where the blast count is not increased and usually cytogenetic abnormalities are absent. So in early MDS, what I recognize as a clinician and others as well, is the challenges of securing the diagnosis of MDS in early phases, especially if clinicians haven't sufficiently excluded secondary causes of dysplasia. So around the time I started my research laboratory, thankfully, there had been efforts to sequence the whole genome or whole exome of patients with MDS. And while there was no singular mutation such as BCR-ABL that you would see in chronic myeloid leukemia, or JAK2, which is mutated in a high proportion of myeloproliferative neoplasms, there were recurring mutations observed in MDS, around 30 or 40 candidates, for example. And they fall into the following categories. So interesting, the top mutations in MDS involve factors that contribute to RNA splicing. Next up are factors that contribute to epigenetic regulation, such as DNA methylation, histone modification, or cohesin complex components. And so just to highlight a few here, DNMT3A is a cytosine methyl writer, and TET2 is a cytosine methyl eraser. Then less commonly, but these are associated more with progressive MDS, you can have mutations in transcription factors, signal transduction pathways, or DNA damage response pathways. And so this was a pretty extensive list, but it was quite amenable to targeted next generation sequencing, and that's what I'm going to tell you about now, and where we've run a lot of this sequencing and gotten a lot of usage out of targeted NGS in the MDS realm. The platform that we chose was from Thermo Fisher, the Ion Torrent platform, and we custom designed an NGS panel, a pan-myeloid panel, if you will. So although we were really focused on MDS, we included genes mutated in myeloproliferative neoplasms and AML. We included 48 genes. I won't go through them on the right. Sometimes we looked at all coding exons or just hotspots. And there were 1,500 amplicons across 2 tubes. And so we amplify selectively these regions in these genes and then sequence them using Ion Torrent chemistry and platforms. So we focused in on this challenging diagnostic area where patients are failing to meet MDS diagnostic criteria by morphology. And we're showing you here in this graph on the left, here are 20 cases of MDS that were diagnosed and 18 cases that we identified as being just near the boundary, quite suspicious for MDS, but we are unable to assign a WHO diagnosis of MDS. And to our surprise, and mind you, these were highly selected cases, that about 78% of those cases where we could not meet the morphologic diagnosis did have mutations associated with MDS. And on average, so the median was 1 mutation, whereas in MDS, the median was about 2 mutations. The other finding was that these mutations especially occurred in some of those top categories that I just showed you earlier over here in the splicing and epigenetic regulators. So TET2, DNMT3A, SF3B1, etc. The other information we gather, in addition to the number of variants or mutations per patient, is how large is this clone? And so we look at the variant allele fraction. And of course, if you have a heterozygous mutation, the VAF, in other words, should be about 50% or 0.5. We were really surprised, and others around the world are finding this as well, is that these suspicious cases, which are we're missing the diagnosis, have identical variant allele fraction to the diagnosed MDS cases. And what this information has told us, and we're expanding the analysis now, is that it seems that these earlier challenging cases, these clones are failing to meet the dysplasia threshold, but we're missing really quite frank molecular disease where there are mutations associated with MDS present and that the clones have expanded quite substantially in the blood and bone marrow. Now, we were focused on MDS, but again, you might have heard of some of these terms. If you haven't, I'll describe them now. Now we're starting to think of pre-MDS or pre-cancer. And there are new four-letter words that people may cuss about, more acronyms being added to our list. And so the term CCUS, clonal cytopenia of undetermined significance, most of those people I just described here, they now would fit into that category because they do not have an increase of blasts. They have subthreshold dysplasia, but there's evidence of clonality in that there is a molecular aberration, a mutation associated with MDS. And so those are the cases that I was describing there. Taking this step back further, and the main focus of this seminar with you and discussion will be about clonal hematopoiesis of indeterminate potential. The difference there is that there is no dysplasia, usually no cytopenias, but there's detection of clonality, and that's the very earliest phase of cancer development, and patients may progress through these stages. Now, we're really missing this CCUS phase, this near MDS phase, and this group in Europe, led by Luca Malcavati, published in Blood, is showing us some nice longitudinal follow-up of patients who fall into the CCUS category. And there's a high risk of progression to full-blown myeloid cancer like MDS. 82% in their study progressed by 5 years and 95% by 10 years. And so we anticipate, and I'm sure Dr. Magalhaes and others are involved with these working groups, that in the next revision of the World Health book, we'll probably be including mutations to help secure the diagnosis of MDS in these challenging cases, because certain CCUS cases resemble low-grade MDS. So for example, having a spliceosome mutation or having one of these epigenetic regulator mutations plus another, those seem to, for example, otherwise resemble MDS with respect to survival in these patients. So we've been really excited about applying NGS in this pre-MDS phase. And we've been applying our panel with others, including Dr. Duarte Nozello and others. And I'll tell you a little bit more about that in a moment, but we've been looking in families and patients with a germline predisposition to getting a myeloid malignancy, such as germline mutations in RUNX1. And this was beautiful work led by Bruno and Margaret, and that I participated in, which was featured in the cover of the September 2019 edition of the British Journal of Hematology. We have also been applying NGS in the context of a large North American clinical trial where we were looking at the effects of hypomethylating agents in high-risk MDS and CMML. And there have been a couple of publications here. We're showing how NGS helps to predict outcomes and treatment responses in JCO series journals. So in the MDS space, we've been showing promise for facilitating diagnosis and understanding better prognosis and treatment outcomes. A little bit more now about this case. And so I'm just highlighting two siblings and just a partial, some of the data here only, but encourage you to go look at Bruno's beautiful study. So the siblings both had RUNX1 nonsense mutation here at arginine 201, which was determined and found in buccal swab. These mutations are also found in their bone marrow. So the first individual, A1, presented presumably with some cytopenias, but the marrow was non-diagnostic. So recall these yellow zone cases that I mentioned to you, they're very difficult. retrospectively applying our NGS in a research setting, we found a spliceosome mutation. And later on, this patient unfortunately progressed to acute myeloid leukemia. So the germline hit in RUNX1 puts them at, lowers the threshold for them to acquire myeloid malignancies. The sibling of this patient presented with MDS and a unique set of acquired or somatic mutations, so those being in TET2 and in NRAS. And so this highlights that there may be particular populations in whom NGS surveillance may be important in looking for disease, and also overlaps with what I told you earlier, is that it's difficult. We do our best as pathologists and cytogeneticists, for example, but applying molecular tests helps us to better stratify and understand. So this patient might have then qualified as a CCUS or clonal cytopenia with such a mutation. And with Margaret and Bruno, we are also conducting some MPN projects regarding NGS, and so watch for some more interesting work coming out of their laboratories. So that was all in the research setting here in Canada, but we have subsequently adopted NGS in the clinical live setting at our hospital here at Kingston Health Sciences Center. Why we went this way was, well, you probably know as well that in the 2017 revision of the WHO book, there are many new molecular features, and this is ideal for higher throughput approaches. So in Canada, we also did not have assays available for many of these features. Also, what helped us was we had early access to a trial version of this panel that Thermo Fisher was designing as part of their OncoMind series. And we already had clinical ion torrent NGS in place, thanks to our molecular director, Dr. Harriet Feilotter. It was being used in solid tumors. And Cancer Care Ontario, our provincial, Canadian Provincial Institute for Cancer Care, provided funding, but only for acute leukemia, but that offered a starting point. Now we shifted to, when we helped with, advise the development of this panel, what we really like about it, it's a combined DNA and RNA panel. So the DNA targets overlap with the 48 genes very well that we designed ourselves. But the real advantage and what we really like about this is that it also has an RNA component. And so complementary DNA is made and you amplify fusions. So there are 29 common fusion drivers, and this panel covers around 700 or 800 possible combinations. So for example, with MLL, there are many possible partners that it looks for. We haven't taken advantage of this, but there's also gene expression that can be measured of prognostic genes in AML. But why we're very excited about this one is that this could potentially, on the RNA side, streamline and help reduce the laborious, time-consuming traditional cytogenetic testing in some cases. And so we're working towards rapid NGS analysis of fusions that are relevant to heme malignancies that may complement or eventually replace traditional cytogenetic testing. Of course, much more work needs to be done there. I'm just going to summarize. So we have a paper at the Journal of Molecular Diagnostics, which is in revision, just summarizing our experience with the first year and a half of this testing. And this is driven by an excellent PhD student lab, Christina Ferrone. So we're reporting on 187 samples of blood or marrow from 168 unique patients with suspected or known myeloid cancers. What happens at our institute is when we're funded for an acute leukemia case, we can run 8 samples on a chip. So we don't, in our smaller center, get 8 leukemias, all at once. And so we queue up non-leukemic cases where we as hematopathologists and in conjunction with the hematologists think that next generation sequencing data would be very helpful in the clinical setting. And these are just some of the metrics of the sequencing. But we then are tracking now clinical utility or actionability. And so remember, these are selected samples where we think NGS will be useful, but 77% of them, these variants or these mutations, meet our criteria for actionability or utility. Most of them facilitate or clarify diagnoses, and then some of them also help to understand the risk profile and have the potential to influence clinical management, such as matching to a drug or affecting the decision of whether to go to an allogeneic stem cell transplant, for example. So what I wanted to show you is just 2 examples of some of the information that came from this. And so this is a schematic of the DNA methyltransferase 3A. And this is a figure from TCGA Genomic Consortium data showing you where mutations are found throughout the coding sequence of DNMT3A. And this large lollipop here indicates that a hotspot in acute myeloid leukemia occurs at this arginine 882. So we've had, just highlighting two patients with AML. Here I'm going to highlight. This is a 67-year-old male who we ran the clinical NGS, and he had DNMT3A, this hotspot mutation. The panel also revealed a mutation in the metabolic enzyme IDH2. This patient managed to get an allogeneic bone marrow transplant and is currently dealing with chronic graft versus host disease. We had a 55-year-old patient with AML who had this other arginine 736 mutated and a host of other mutations, so TET2, NRAS, and the phosphatase PTPN11. Unfortunately, she initially failed induction. She did eventually get to allo-BMT, but she relapsed, and she unfortunately expired. And so this is some of the molecular information we're now getting on our leukemia patients, which are helping in the management and better stratify them into risk categories. But I really want to talk about clonal hematopoiesis. And so I'm going to show you some data on people in the community, not in our hospital, but people, healthy people in the community who we were studying, who consented to have their blood tested for this exact same myeloid panel. And this is work that I'll describe a little bit more. It's published in Blood Advances in 2019. So we looked at 359 hematologically healthy adults who are at least 65 years of age in the community. And 9% of these people have detectable mutations in DNMT3A that are similar mutations to what you see in myeloid cancers like AML. So for example, the last two mutations that I highlighted for you, this one and this one, we have patients in the community with these exact same mutations. They do not have leukemia, but we wonder about their risk, obviously. So the reason we got interested in this is we were naturally shifting our focus to earlier stages of MDS and earlier stages of myeloid malignancies. And at the same time, it's been known that among our limited number of hematopoietic stem cells, or HSCs, that mutations are going to randomly appear over your lifetime and accumulate over your lifetime. So DNA damage that we cannot repair will effectively get carried forward. And it's been calculated that approximately once every 7 or 8 years, on average, each of these hematopoietic stem cells in your body is going to accrue a mutation somewhere in the genome that's going to be carried forward. Thankfully, though, most of these do not impact hematopoietic stem cell function. They don't normally cause MDS or AML. But as a stroke of bad luck, if you will, or inevitability, they will land sometimes in driver genes that provide a selective advantage or proliferative advantage. And so there is, at least for now, this inevitable accumulation of mutations that occurs in stem cells. And this is what leads to these pre-leukemic or early clones. So we set about to study this. When can we first detect these in the community, in the healthy community? And I gave you a preview of the DNMT3A results. And of course, lots of others around the world have been interested in this, and there's been several publications about this. But we used a Canadian grant from this cancer society, recruited our own patients in the community, and screened for these early mutations. They were recruited in Toronto through a long-term care facility called Baycrest and through geriatric family practice at Sunnybrook. We obtained their blood, and we profiled them for these 48 myeloid cancer-associated genes. And our threshold of a detection for mutations is around 2% variant allele fraction. And, I've already told you, it's fairly common, and you've probably heard about CHIP, some of you. So this is how common it was. We were quite surprised to see this, but this is being reproduced around the world in various extents. Overall, in our cohort, 23% of these older adults had detectable clonal hematopoiesis, or these pre-leukemic mutations. And we saw a trend to an increase in age, and that's what others are seeing as well. Now, these mutations are dominated by TET2 and DNMT3A. By far, they're 1A and 1B. They're far ahead of the others. And it's very interesting to think about the unifying biology of cytosine methylation, regulation and dysregulation of cytosine methylation, and how that provides a clonal advantage. And of course, people are very interested in that. But we did find some other genes, especially splicing factors, and this overlaps highly with MDS type of mutations. On average, these clones are small. So the average variant allele fraction is 10% in peripheral blood cells. Again, recalling there's a maternal and paternal allele. So these are usually heterozygous. So if we multiply this by 2, 20% of blood cells, or 1/5 of blood cells circulating in their body are mutant, and 4/5 are not. And so this was surprisingly common. And if you'd like to read more about it, our paper is in open access. I would now like to talk about the impacts of clonal hematopoiesis on malignancy risk. I'm going to show you now some data from tandem, very large, high-profile papers in the New England Journal of Medicine. As opposed to our study where we specifically recruited people, which took a lot of work, and sequenced them, what they did here, which was very, very slick, was they accessed already available peripheral blood sequencing data from genome-wide association studies. And so these were cardiovascular and metabolic disease cohorts and psychiatric cohorts. So they had no known hematologic diseases. And here, like we were showing you earlier, there is this this increase in the rate of CHIP or clonal hematopoiesis as people age, and especially after the age of 60 is when you start to see an increase in its prevalence. And so, like we found, and like others have been finding, that the mean fraction is around this 10% or so. They did have the luxury of looking at longitudinal outcomes, and the risk of hematologic cancer, the hazard ratio is about 11. If you have a very large clone, that hazard ratio increases at the larger the clone is. And so, for example, they looked at ones where it was over 10%, closer to 20 or 30%, and the hazard ratio could reach up to 50, for example. Just like we are finding and others are finding, it's dominated by these big 3 genes, especially DNMT3A and TET2. And these are genes that are commonly mutated in MDS and AML. And so around this time, the definition of clonal hematopoiesis of indeterminate potential was established. And that's when you have a variant allele fraction of one of these hematologic mutant genes at least 2%. And the indeterminate potential part came from the fact that not everyone progresses to malignancy. And at that time, it was hard to determine, or it was more indeterminate about what the trajectory is for an individual patient. If you're more of a visual learner, and this is an excellent review from David Steensma at Harvard, what he's showing us here is a representation of hematopoietic stem cells in a person's body, and they are accumulating mutations over time. So on the bottom row, this stem cell acquired a green mutation. It didn't provide any advantage, but it marked that clone moving forward. Likewise, here's one with a blue mutation. But this clone that had initially a sort of benign purple mutation, then what started the ball rolling was a mutation in either TET2 or DNMT3A that provided an advantage and expansion for the clone. And then with additional mutations, that's when you can see patients progress to the other stages of frank malignancy like MDS and AML. It's been calculated that the annual risk of progressing in a patient with CHIP is about 0.5% to 1% risk per year. And for those of you that are hematologists, you'll appreciate that this is very similar to what you see in monoclonal gammopathies and their relationship to multiple myeloma and the annual risk. And at this time, people, and still, people are cautioning, though, against going out and routinely looking for CHIP. But it does represent a tremendous opportunity of a window we never appreciated before or could detect before of pre-malignant clones. So this gets us thinking now about Darwinian principles again, and where we're practicing in this phase. So currently we're focused on when patients present mostly with cytopenias or increase of blasts that are reflective of MDS or leukemia. But we're missing potentially this cryptic period here, this pre-leukemic or clonal hematopoietic phase, where over the period of many years, the clone has been progressively acquiring mutations. And then it is only when it crosses a certain threshold that we clinically can detect them and they come to presentation. And while we have some successes with MDS and AML, we're obviously can see very poor outcomes. And so is this a potential opportunity where we could detect earlier and treat earlier? And that's what I would like to discuss a bit more as we continue along. I was focusing on leukemia, AML, and MDS, but there are implications for other cancers, other hematologic cancers or non-heme cancers. So first of all, this study in JCO by Gibson et al. Showed that in lymphoma patients who were undergoing an autologous stem cell transplant, that the presence of clonal hematopoiesis was associated with an increased risk of a secondary or therapy-related myeloid neoplasm, and reduced overall survival in those lymphoma patients. At Memorial Sloan Kettering in New York, they have some beautiful work looking at CHIP, also increasing the risk of therapy myeloid neoplasms and decreasing overall survival in oncology patients. And some other points to consider from these types of studies is that we have to be careful about misattributing CHIP mutations to solid tumors. So for example, if there's a leukocyte infiltrate in a tumor and you're measuring mutations in the bulk tumor, could some of those be coming from CHIP? The other is that with the push to liquid biopsies and looking for cancers in cell-free DNA and plasma or serum, that we have to be aware that clonal hematopoiesis contributes substantially to cell-free DNA because those are circulating blood cells and that's the medium that they're in. And so these are some considerations for non-myeloid cancers. We'll talk about a project that we're doing again with Rena Buckstein, the hematologist in Toronto, and with student in the lab, Olivia Lopez. So what we were wondering about is that CHIP is present in lymphoma patients. And as some of you are probably aware, it's puzzling because when patients are being treated for their lymphoma, some of them experience complications and require dose adjustments and dose delays, and others just seem to sail through. And so our hypothesis is that CHIP, with a diseased myeloid bone marrow compartment, could affect blood cell reconstitution after chemotherapy and may put people at risk for neutropenia, anemia, infection, for example. And so that's a project that we're underway to try to answer, why do some lymphoma patients experience chemotherapy complications while others don't? Does it relate to CHIP? So what we expect in this project is that our hypothesis is that lymphoma patients will experience more chemo complications if they have CHIP. We're also interested in the other side. So the selective pressure that is applied by the chemotherapy, what does that do to the CHIP clone that's inside of the lymphoma patient? Could that lead, because we are aware it could sometimes lead to therapy-related myeloid neoplasm. So does that influence clonal evolution in these patients? So these are some things we're really excited to look at in this study that is underway. With some colleagues in anatomical pathology and an oncology department here at Queen's University and Kingston Health Sciences Center, we're looking at the influence of CHIP in patients with metastatic melanoma, and specifically wondering about the influence CHIP may have on the response to immune checkpoint blockade therapy. And conversely as well, like in the lymphoma project, when patients with melanoma are put on these therapies, what influence or impact might that have on the CHIP clone size? So you can already see that we're starting to reach out beyond myeloid cancers, and there's tremendous interest in the oncology community in clonal hematopoiesis because such a large swath of the population, especially older population, have this. Obviously their primary cancer is the main issue, but a lot of them have this underlying clonal hematopoiesis. All right, I would like to talk now about and shift over to non-hematologic disease, which again, as I alluded to earlier, it was a bit of a surprise, but in retrospect, this may make sense. And the punchline is that it relates to inflammation. Clonal hematopoiesis can contribute to inflammation and thrive in inflammation, and so other inflammatory diseases can be influenced by this state. So the original New England Journal publications and then a follow-up one in 2017 show that CHIP was associated with increased all-cause mortality, diabetes, coronary heart disease, ischemic stroke. But again, I mentioned there was another set in this publication here where they looked in psychiatric disease cohorts and there was no association with psychiatric disease. The follow-up New England Journal study showed that early onset MI in younger individuals was indeed associated with clonal hematopoiesis. I told you why that is, but really this was puzzling initially. And to put it in context as well, so the presence of CHIP is on par, this is multivariate analysis, on par with many of the other risk factors associated with cardiovascular disease, and only surpassed by age in this study here, and type 2 diabetes. So it's really something of great interest in cardiology right now. Cardiologists are very interested, but they're not going out and looking for this. But you can imagine if someone has CHIP and they're at risk of heart disease, it might be important to modify risk factors that are modifiable in these people. So here is one of the answers. So TET2, the most is known about this. This is one of the CHIP drivers. The mutations are inactivating, and when TET2 gets inactivated, this increases inflammation. So this was a tongue-in-cheek sort of commentary in Nature Review and Immunology, Arnold Schwarzenegger, the Terminator. So TET2 is really, its job is to help terminate inflammation. And when TET2 gets inactivated, inflammation goes rampant. What I'm showing you here is this was the very first publication to demonstrate it by this group out of China. So TET2 is required to resolve inflammation, and specifically repressing IL-6. There have been a number of studies. We contributed one here in experimental hematology, where we show TET2 is restraining inflammatory gene expression in macrophages. Just one snippet of data to show you from the study. These are macrophages obtained from the mouse peritoneal cavity of TET2 mutant mice and control wild type mice. And this is nanostring gene expression data. And what you see is this big cloud of overexpressed genes that include, as you see here, inflammatory cytokines and chemokines. So with TET2 disrupted in these mouse macrophages, there is spontaneous and massive inflammation. So the connection to cardiovascular disease, and in subsequent very elegant publications too in Science and New England Journal, is at least partially mediated by monocytes and macrophages, these mutants. So they go rogue, if you will. And as you know, monocytes, macrophages, leukocytes normally infiltrate body tissues. They infiltrate atherosclerotic plaques. They aggravate inflammation and aggravate cardiovascular disease. And in these mouse models, they showed some intervention with anti-inflammatory therapy. And there has been some sub-analysis of clinical trials, such as the CANTOS trial, where there was blockade of interleukin-1, and it showed benefit, especially in patients with clonal hematopoiesis. So there's great interest in potential therapeutic avenues in heart disease and recognizing those with clonal hematopoiesis, such that anti-inflammatory therapy could be applied. But at this point, that's as far as that has gone. So the list of diseases that CHIP is associated with is growing. And in our Blood Advances paper, we looked at other comorbidities, and we saw a strong association of CHIP with greater than one mutation, or DNMT3A, with chronic pulmonary disease. I reached out to a cardiologist and their head of medicine here, Dr. Stephen Archer, who specializes in pulmonary arterial hypertension. And we examined our mice, our TET2 knockout mice, and they have spontaneous pulmonary arterial hypertension. This figure shows you their right ventricle systolic pressure is increased, the total pulmonary resistance is increased, and these beautiful fluorescent images of vessels show microvessel rarefaction in the TET2 knockout lungs. And these are all features that you see in pulmonary hypertension. And in our paper we published recently in Circulation, we also looked in conjunction with colleagues in the US in a large human biobank of PAH, and have been finding association between TET2 mutations and DNMT mutations in blood cells and risk of human pulmonary arterial hypertension. And so CHIP is affecting the lung in addition to the heart, it seems. This is some more data from our Blood Advances paper. And we were able to obtain the performance status and a Charlson Comorbidity Index and clinical history of these patients, and as well measure inflammatory cytokines in their peripheral blood. And so we found CHIP was associated with increased frailty and increased comorbidity, possibly novel comorbidities that we're exploring now, such as thyroid or gastrointestinal dysfunction. And what we're showing you here is that serum inflammatory cytokines are increased, so such as IL-6 and TNF-alpha. And in our study here, it was not meeting significance, but interleukin-8. And so CHIP patients, CHIP subjects in the community seem more frail, have more comorbid diseases, and have early signs of inflammation in their bodies. And I highlighted IL-8 because I'm going to now shift some attention to Dr. Sylvia Magalhaes and her group and Ana Cília dos Matos. Here they looked at IL-8 in their publication in 2017, and nuclear factor kappa beta, an important inflammatory transcription factor, and that there was a positive correlation in myelodysplastic syndrome patients. And so remember, we're interested, this CHIP is sort of a precursor to MDS, and so maybe it's not surprising that some of the early features of dysregulated inflammation are going to be apparent in people with clonal hematopoiesis, and this is perhaps in line with what you would see as the patient progresses through. And it was interesting to see their finding with IL-8 as well. And as well, here in their study in PLOS-1, they looked at respiratory muscle impairment and reduced forced vital capacity, and recall how we're finding an association with chronic pulmonary disease as well. And they're wondering in their paper, is inflammatory signaling the culprit? And so in MDS and in CHIP, where these mutations occur, we believe that that is the case, and that immune dysregulation is contributing to these comorbidities. We recently published a review article that Ana Cília took the lead on, and we are going to be doing some collaborative work with them as well, and looking at particular mutations in the MDS setting and understanding more about specific and shared immune dysregulation that occurs in these disorders. Now, it's a vicious cycle. So we're just saying now that CHIP contributes to inflammation and MDS has inflammation, and they seem to share these properties. This favors expansion of the mutant clones. This was work by Samuel Abagunde, who was an MSc student in the lab. He took hematopoietic stem cells from wild-type TET2 mice, so in green, and knockouts shown in white. And what we did was we cultured them in vitro and grew colonies from these hematopoietic stem cells in increasing concentration of TNF-alpha. And this is the normal response. And so with a chronic inflammatory environment, normal hematopoietic stem cell production gets shut down. Paradoxically, as you can see here, the opposite had happened in the TET2 mutant. And so in an inflammatory environment, the TET2 mutants were favored. And that's because they're resistant to apoptosis and pyrotosis. And some other studies have extended these findings that we published earlier in experimental hematology. So to bring this all together, I mentioned the vicious cycle, inflammation contributing to pathogenesis. This is what we postulate, and is a working model now, is that you acquire a mutation that predisposes to clonal hematopoiesis. This provides a stem cell advantage, but the stem cell is still able to produce progeny like macrophages and neutrophils. These have abnormal function, especially increased inflammation. And this inflammation, whether driven by the mutant cells or pre-existing in a host with comorbidities, leads to favorable expansion of the CH clone. And because these do contribute to inflammation, that this would exacerbate inflammation and comorbidity in the host. And so several labs around the world are very interested in pursuing this, because you can imagine this could be a potential therapeutic avenue. I'm going to go a little more quickly through this. So the main focus has been on monocytes and macrophages, but our lab is now studying neutrophils. And this is a schematic showing you the differentiation from a blast to a segmented neutrophil. And during the stage of maturation, various proteins are being produced and granule components are being produced, such as myeloperoxidase and lactotransferrin. So work of Alina Cook, who's an MD PhD student in the lab, and Michael Rauh, we've been looking at RNA sequencing of subjects with CHIP and without CHIP, and finding increased expression of neutrophil granule components. So here we see lactotransferrin, myeloperoxidase, and these other genes are also granule components. So this early work suggested that CHIP may disrupt some of the gene expression, CHIP mutations in neutrophils. And we've looked now in the serum, so these candidates that seem to be overexpressed at the transcript level, we detect more protein, more myeloperoxidase circulating, and more lactotransferrin circulating. And so we believe this may be some evidence that there are other mediators besides the interleukins, for example, that are being elevated by these CHIP type of mutations. And we're wondering, how does this impact the function of neutrophils? So this is with a study with mouse neutrophils. We challenged them with gram-positive Staph aureus, and the knockouts here, the KO, show impaired ability to phagocytose Staph aureus. Here we're looking at their motility in real time in live cell imaging, and they're impaired in their motility. So these results suggest that perhaps there's neutrophil dysfunction in clonal hematopoiesis, and that this could translate to increased susceptibility to infection. We're doing some RNA sequencing to accompany these, and we're delighted to see that indeed pathways related to motility and migration are downregulated in these knockout neutrophils. So we're extending our analysis now to human peripheral blood cells and human neutrophils, but we believe that it is not just monocytes and macrophages that contribute to CHIP pathogenesis, and that the more common leukocyte neutrophils may also play a role. So thinking of the infectious disease and the opportunity provided by COVID, we were really struck by the fact that some of the risk factors and associations with CHIP, such as prevalence with age and male sex, pulmonary inflammation, and this macrophage cytokine storm, were also associated with risk of severe COVID-19. And I was fortunate to connect with a critical care physician here in Kingston, David Maslov, who is enrolling subjects in this genomic study, which initiates in the UK and is driven by Kenneth Bailey. And you might have heard of genomic because they have been interested in the host genetic susceptibility to infectious disease, and specifically to COVID-19. And they recently published an article in the New England Journal looking at germline risk of severe COVID-19. And so we really don't have a lot of patients yet in Canada, but we're partnering with this group. And in addition to looking at the germline, we have some grant funding to look at clonal hematopoiesis, or CHIP, as a contributing risk factor to severe COVID-19 illness. During the lockdown, I also reached out and was able to be part of this COVID-19 host genetics initiative. And a sub-project of theirs relates to clonal hematopoiesis. And this is especially driven by Philip Awadallah, Pradeep Natarajan, and Kelly Bolton. There's a preprint that has been submitted to medRxiv, and the link is here. And this has been submitted in tandem to a peer-reviewed journal with another CHIP COVID-19 manuscript. But indeed, CHIP is associated with increased risk of severe COVID-19, albeit modest. So the OR is 1.9, and this was a fairly small study. But looking at patients in Memorial Sloan Kettering and in Korea, those with CHIP had more severe COVID-19 outcomes. Also, they were able to look at Memorial Sloan Kettering in their large solid tumor patient cohort, and finding that CHIP was associated with other diseases such as Clostridium difficile infection and infections with strep and enterococcus. So recall back to our primary mouse study suggesting that CHIP might actually increase the risk of infection and make neutrophils dysfunctional. So it's encouraging to see at least these early studies suggesting that CHIP may be a risk factor for severe infection, and this warrants further investigation. So people are really considering now, because this is a common phenomenon of aging. Blood cells naturally infiltrate throughout the body tissues, so we know already they're contributing to ischemic heart failure, in addition to atherosclerotic heart failure, diabetes, thrombosis, lung disease. So people are beginning to think about neurodegeneration, and we have a small grant to look at that locally here. We have a superstar PhD student who's an internal medicine resident who's really interested in nephrology, and we're partnering with local and external collaborators to look at the role of CHIP in kidney disease. And these mutations are accumulating throughout the body. The difference perhaps is that naturally blood cells infiltrate these body tissues. And so if they are having any effects on gene expression or inflammation, that they may have an influence throughout the body, because that's naturally what they do and where they go. Okay, I'm a little past when I thought we'd be maybe 45 minutes, but is it all right if I finish off with just a few short slides on rewards and risks?
Go ahead, Michael.
Okay, thank you. So, although people have cautioned not to go out and look for CHIP, this is happening. So this was Ross Levine, who's a famous hematologist, oncologist at Memorial Sloan Kettering, and they were one of the first to open a CHIP clinic. And these are popping up. These are popping up in some of the larger centers, especially in the US, but also in Toronto here in Canada. They're not going out to look for people with CHIP. The way they are discovering them is that they're oncology patients and they've had sequencing done on their tumor and maybe paired on their blood, and it's an incidental finding. Or maybe a person has submitted their blood to a direct-to-consumer testing, genetic testing, and are finding out that they have a mutation associated with clonal hematopoiesis based on their own accord. Where people are envisioning this initially, and he's saying here, we have to start to learn how to care for people with CHIP. So in Toronto, for example, it's a partnership of hematology and cardio-oncology. So in oncology patients where CHIP gets identified, the hematologists, cardiologists, oncologists are working in conjunction to optimize the health of those patients. Our partners at Sunnybrook Hospital in Toronto are looking very carefully at MDS patients with mutations like TET2, for example, and others, and trying to optimize their cardiovascular health. So insights we're gaining from CHIP could also be relevant to myeloid leukemia patients like MDS. So we are also learning more precisely about risk for individuals. This was work that was published in Nature with the provocative title of Prediction of AML Risk in Healthy Individuals. And it's work driven by investigators in Toronto, in Israel, and in the UK. They accessed a European population cohort bank called EPIC. They identified people who enrolled in this population cohort and donated blood when they were healthy, and then later developed AML. So on average, about 6 years later. And they matched these people to 414 healthy individuals. So the question they asked is, okay, how common is clonal hematopoiesis in these people who remained healthy versus people who got AML? And if it's more common in people in AML, are there particular signs that we could have recognized as to why they were more prone to get AML, whereas someone else has remained AML free, for example? And so, if you will, is there a crystal ball where we could predict? And maybe this is not surprising. There's a pretty impressive paper, but people who are likely to get AML are more likely to have CHIP mutations in driver genes, cancer driver genes, well-annotated driver genes. They are likely to have larger CHIP clones. So the larger the clone, the more likely you were to progress to full-blown leukemia. And there was enrichment of certain mutations. So not all genes were equivalent. And so beginning to build a picture at the molecular level of what more precisely predicts risk. But in order to identify those people, we would have to sequence them. So the other part of this paper, which was very cool, was that they asked, can we just use routinely available data? And so here they access this large Israeli CLALIT database of routine complete blood cell counts and electronic medical records. And just looking at this and applying machine learning, they were able to predict AML development 6 to 12 months prior to diagnosis. It was a fairly specific model that they had, but not very sensitive at the moment. And so the idea with this would be, could we detect when people are in the community getting blood work done, that there are some features there that are suggesting they're on their way to getting MDS or AML, and maybe they would be the type of people we would want to focus genetic surveillance on. Now, the other thing that people would always argue is if we can identify this, we can't do anything about it. And that's true, not yet anyways. However, there may be potential strategies to mitigate CHIP risk. So TET2 here, we're showing in the schematic, it facilitates the hydroxymethylation and then demethylation of cytosine in the DNA. But vitamin C is a cofactor for TET2 activity. And remember that TET2 mutations are inactivating, but they're usually heterozygous. So that means that there is one functional good copy or wild type copy. And so what some high profile studies have shown, and here example in Nature, is that increasing the vitamin C level in the mouse experimental model or in vitro with the human cells can restore some of the wild type TET2 activity and dampen down the leukemogenic potential. So vitamin C is something that people are interested in, although you need super dosing of that. So with collaborators, we're really interested in exploring other options for targeting these clones, and many people around the world are presumably doing this as well. And so these are just some of the examples of that. So finally, just about to conclude, I've talked about CHIP in hematopoietic system and cancer risk and disease, but really it seems that this is a paradigm, this paradigm of somatic clonal expansion is happening all over the body. So if you'd like to learn more about this, I've linked to a few review articles recently, but there's examples in skin, in esophagus, brain, liver, endometrium. Mutations are naturally occurring over time and leading to microscopic clonal expansions within those tissues. So they are restricted in space, but there is some selection, interestingly, of particular mutations with aging, some of which would predispose to cancer, and some which could relate to dysfunction of those particular tissues. So to summarize now, what we talked about was now how we're focused on the upper level when people come to our attention with multiple mutations. But I really wanted to just, for you to consider, it's a long way off, and even in Canada and the US, but could we potentially be looking in this period of time with appropriate consent and safeguards, for privacy, insurance, for example, and especially if we understand better about risk and surveillance, and eventually if treatments become available, could we intervene much earlier and be much more successful? I'm going to skip over this for now. Actually, well, I'll mention it briefly. So what I'm just showing here is the current practice. So here I am sitting in my office now talking to you in this hospital. We have to wait until patients come into our hospital before we could start to apply these molecular tools. Meanwhile, they're in the community, and family physicians and primary care physicians are doing great work there, but we're disconnected from that information. And it may be that certain physicians are not recognizing subtle trends in the blood counts, which is understandable, or maybe there's variable concern on the part of the patient or the clinician. So what we're really at the early stages of looking at are reaching out of the hospital and into the community as pathologists and changing our role. So in Kingston here and in Canada, we have a Canadian primary care sentinel surveillance network. And they are involved, just as I said, in disease surveillance and in piloting new initiatives. And so we're just beginning to talk to them about potentially, from what we're learning with our studies of clonal hematopoiesis, reaching back into the community, learning how, if this is possible, how might we go about it, and how might we pilot. But the idea would be there would be automatic flags for the physician. So in the routine blood work, you may say machine learning is telling us that there's trends in the RDW or MCV, and this patient should be investigated further. Standardizing clinical workup and guidelines. So do B12 folate, look liver function, et cetera. Really helping to guide the screening and surveillance for malignancies much earlier on. So in summary, I hopefully have discussed with you how CHIP is common if you haven't heard of it, or maybe some new aspects if you have heard of it, how it increased the risk of heme malignancies and other diseases, especially of the cardiopulmonary unit, how they intimately are involved with inflammation, they increase inflammation and they thrive in this environment, and how CHIP surveillance and intervention is in sight, but of course, much, much more work and many precautions should be involved with this. There are many people to thank. I'll just briefly do that now. I've tried to as we've gone throughout. Members of my laboratory, collaborators in Toronto, McMaster, and Cleveland Clinic. Lots of funding organizations, including the Ontario Institute for Cancer Research, and my wonderful colleagues in Brazil at Ceará and in Campinas. And let's see if I did this right. I really enjoyed our first trip to Brazil. I've told my kids about it, and again, we're really privileged in Canada, but with the lockdown, we really are itching to travel, and it would be wonderful to take them to your country and to visit your country one day. So I thank you again for your attention, and sorry we've gone right to the hour. I really hope to discuss some things with you now and answer your questions. Thank you very much.
Thank you, Michael. Well, that's absolutely right. And we hope you can bring your children to Brazil very soon.
That sounds good.
Does anyone have any questions?
Michael, first of all, thank you very much. It was very comprehensive and very clear. And I'm just thinking, you briefly talk about to use RNA strategy with some advantage. So I'm just curious if you already established a biobank, and what is your strategy now in terms of the samples and how you approach, for example, the patients as example of our collaboration. There was a longitudinal evaluation of few cases. So what are you doing right now in terms of to establish a biobank based on what you discussed?
Okay. Yeah. Thank you, Margaret. So right now, we're not replacing, I guess I'll talk about the clinical first, the clinical side. So the NGS panel runs DNA and RNA, and we can detect fusions, that would normally require FISH probes, in situ hybridization probes, or cytogenetics. We're not replacing it yet. We're running it still in parallel, but we're finding, 100% concordance. And if anything, so we had an example of an eosinophilic neoplasm, which was driven by the rare PCM1 JAK2 translocation. So the marrow was being investigated for eosinophilia, and just within a couple of days, the NGS results came back with PCM1 JAK2. We opened up our WHO, we're like, wow, that's that's right in there. And so the cytogenetics were not even, at the stage yet, understandably. And so we were able to inform the laboratory that, look what we're finding here on the RNA fusion side, and indeed they confirmed the abnormality of chromosomes 8 and 9, and so that pointed to a diagnosis that I'm not sure we might have missed, for example. So what we would really like to do is to show the concordance, and then maybe we would then progress to a stage where we would run the NGS and consider how to triage. So if there's no finding, or if it's important to look with cytogenetics, we might add that. But it could be like if we find, for example, BCR-ABL, or for example, core binding factor translocation in AML, it may not be necessary to do cytogenetics on top of that. So it's a work in progress. There are some other laboratories running this panel, this Oncomine myeloid panel, where they are running it up front, not doing as much traditional cytogenetic testing, and we're not at that phase. The other aspect is that it's a targeted panel, but it does cover hematologic hotspots on chromosomes. It might also be possible to get copy number information. So for example, if there's deletion or gain of chromosomal regions, NGS might also offer that opportunity. So, but I think a lot of work still has to be done. On the research side, we're trying where possible to bank RNA. And so, for example, if you guys have RNA, but this panel is really focused on, it's more focused on leukemia drivers, or so I think, for example, with your interest in MPN, it's probably might not be as rewarding, as opposed to if you're looking for gene expression more broadly, by RNA sequencing or some other means. I don't know, does that answer?
Yes, perfect.
I think Carolina wants to ask a question. Carol, do you want to type it, or can you?
Yes, I have a question. I noticed that you used buccal samples to pair the NGS experiment. Did you have problems with contamination with tumor cells? So
we have that melanoma project. We're just collecting the peripheral blood. And in the lymphoma project, we're just for now sequencing the peripheral blood. But absolutely, if you were to sequence, a solid tumor, that you have to watch out for contamination. And some people have published on that, the fact that you can get clonal hematopoiesis mutations contaminating solid tumors. And especially if people are looking in cell-free DNA, that you have to, if you will, now subtract the clonal hematopoiesis mutations before you even look for solid cancer-associated mutations. We don't have experience with that yet, but people definitely, you have to watch for clonal hematopoiesis in oncology genetics.
May I make a question? It's very discussed, a lot of discussion about it's the frequency of secondary myelodysplasia after chemotherapy. If it is more due to an acquired clonal hematopoiesis, or some people has a germline mutation, and then it's from the beginning on susceptible to have a secondary myelodysplasia after chemotherapy. Are there different gene lesions or mutations or polymorphisms, or are sometimes distinguishable or not?
Thank you, Irene. That's a great question. I think there's a little bit of both. So I'll first talk about the somatic or acquired side. And so what seems to emerge, it seems that, so a few studies have shown that there are pre-existing P53 or other DNA damage response pathway genes like PPM1D. There are pre-existing mutations that before the patient sees chemotherapy don't have really much advantage.
Mm-hmm.
But there are definitely, when people, so there was a nice paper, the Memorial Sloan Kettering group has published so much on this. So they, for example, the biggest study, and they showed in oncology patients with radiation or chemotherapy, it's selected specifically, especially for DNA damage response clones like P53 and PPM1D mutations. So clonal hematopoiesis with DNA damage response mutations is selected for with chemotherapy. So that's one thing that's been discovered. I agree, though, too. I think you have to factor in the germline, and people obviously have different ability to repair DNA damage or are already at a certain threshold, and so that definitely should be another consideration. Right now, we don't know enough. Like, we wouldn't recommend withholding chemotherapy for a lymphoma or a cancer because someone has clonal hematopoiesis. But investigators are trying to determine, might we be able to pick out people at really high risk of getting a secondary therapy-related myeloid neoplasm? How would you manage those? And it might be that in those people, you might reconsider your choice of therapy for the primary cancer if you were going to put them at very high risk of getting a secondary, like lethal myeloid neoplasm. It's an area of great investigation. That's an excellent question and thoughts there.
Mm-hmm. If I can make another question, because the association of multiple myeloma and MDS is very studied and discussed, and because multiple myeloma has on its microenvironment a lot of inflammation mediators and chronic inflammation, and do you think that this kind of microenvironment alterations, do they favor the association with MDS in these patients?
Yeah, absolutely. There's been some work in that area. I saw at ASH, I think they might have published recently, but Irene Gabriel, I think at Dana-Farber. So absolutely, there's some relationship. So they looked at clonal hematopoiesis in myeloma patients, and undergoing various therapy. And so I believe the results were like other cancers. If you have clonal hematopoiesis and myeloma, you have worse outcomes. But there were some interesting findings regarding the therapies, the different therapies that patients have and the influence. And I'm trying to recall, but maybe something about lenalidomide, and of course, that can modulate the immune environment. And there was definitely a difference in the outcomes and what happened with the chip clones based on the type of myeloma therapy. And so, yeah, absolutely. We see that here too, frequently where you have co-occurrence. So there, it's a consideration in other malignancies like myeloma as well.
I think the next up in line is Marcus. Do you want to ask your question?
Thank you for your lecture, Dr. Rauh. I've noticed that you transplanted 2 patients in your MLL cohort. My question is, did you look for CHIP mutations in those sibling donors? And if so, did you find any relationship between these CHIP mutations and development of and incidence and severity of chronic graft versus host disease?
Wow. Yeah, so you guys are touching on really great areas that people are asking amazing questions. So full disclosure, we're a fairly small tertiary center. So our patients will go to Ottawa or Toronto for the allogeneic transplants. We do auto transplants here, but yeah, it's an active, it's a big consideration. So especially in Boston, people have been looking at this. Yeah, I guess first of all, if someone has a germline predisposition, we obviously would want to be careful about, a sibling donor when there's a germline predisposition and screening for that. But it seems like though in like unrelated donors, is that there's a trade-off. So of course people will be worried about secondary donor-derived leukemia, right? And that's what I think you're thinking about. So those are rare, but I think that is a possibility and something that people were worried about. But paradoxically, there was an ASH presentation this year. Because these CHIP clones cause more inflammation, there can be an advantageous graft versus leukemia effect, all right? So they looked at people who were donors. They looked back in time, I guess, in Boston, and people who had DNMT3A CHIP. The outcomes were better. Survival was better when the donor had DNMT3A CHIP. But the trade-off was they got more chronic graft versus host disease. So probably, again, that inflammation coming in. So you are, I don't know. Personally, though, would I want to have a donor that has DNMT3A CHIP? I don't know. I don't think so. If I had a choice of someone without it, probably not. But what they showed is maybe it's not as bad as we thought. And maybe, interestingly, that inflammatory aspect led to more graft versus leukemia and better outcomes, but with the trade-off of more chronic graft versus host disease. So, and there's an interesting, I think in blood or blood advance, there's like a pro or con. Like there was a debate about, should we screen donors for CHIP? Should we not? So that's thanks a lot, Marcos. That's really an area of great interest. And I'm not actively involved with it, but I just find that fascinating that there were some better outcomes when donors had CHIP.
Okay, thank you.
Any more questions? So Michael, as we wait for other questions, I'd like to ask you, are you biobanking germinative DNA samples? And there's been, I think, in Nature, a recently published paper trying to establish relationship between germinative DNA mutations and predisposition to the development of hematopoiesis. I don't know if that's something you have looked into or are looking into. I'd like to know how.
Yeah, I just missed Bruno at the start. So you asked me about banking. I just missed a couple of the words at the start. You asked me about banking.
Germinative DNA samples along with DNA samples from peripheral blood or.
Okay. So no, we are not. But that's a really important point. So even though we're focused on somatic mutations and an oncomine myeloid panel, that we have to be responsible in thinking about, we're going to uncover some germline mutations. And Lucy Godley, so for example, in Chicago, is really a big proponent of this. So we're not currently doing that, but what we've decided, it's an area of development and we have to watch for this. So for example, if someone comes in with AML, and you would know this very well, obviously, if they have a RUNX1 mutation in their AML, and especially if the AML is rampant and the VAF is near 50%, we don't know, is that just because the disease is so widespread and it's somatic, or do they actually have the underlying germline? So what we decided is we're still, then after induction chemotherapy, we're trying to repeat the NGS testing, and especially if they're in morphological remission, and then you see the RUNX1 mutation go down to undetectable or 0, then you could be confident that it is not in the germline. If the converse happens and they go into morphologic remission and all of the other mutations go away, NPM1, FLT3, but the RUNX1 sticks around, obviously then that's someone we want to refer to genetics. But people like Lucy Godley say, well, while you're getting the bone marrow, you're going through the skin, why not get a little bit of skin while you're at it? and collect that and bank it at the same time in case you need to use it. So we are not doing that, but we've decided what I just told you now is that if there's something suspicious, then we would refer them. But even though we're focused on somatic mutations, we're going to be uncovering. And of course, you know as well, that people are estimating that we're underestimating germline contributions to adult myeloid malignancies, and we have to be more aware of this.
So if we may have one question about what to do when we have this new information, especially for individuals that don't have any clinical operation. And as you showed, we know that the shift can increase over age. And you said about, in one of our next slides, some strategy that in the primary care in Canada, that these individuals can follow later. So my question is, once you detect some of this high-risk variation, what do you think that we are now prepared to do? How we will follow these individuals? So
Yeah.
of course we know that there is a research purpose here, but there is also the practical issues. Once you detect that, what do you recommend the very high-risk variations?
Right. So of course, to qualify, hopefully I did earlier, that this is something we really need to work on and consider very carefully and closely. And it's probably far off, but maybe it's in sight. So right now, there are some recommendations. I think it's more opinion, provided by these leaders in clonal hematopoiesis who say that if you find it incidentally, then maybe you should follow this patient watch their blood counts, maybe every 6 months or 12 months, maybe do a baseline bone marrow and then repeat the bone marrow as indicated. But right now, there is not a lot of guidance about what to do, right? And of course, as hematologists, I can remember when CHIP was first being described and I was at ASH meeting, and I'm a lab physician, I'm excited about it. And hematologists around me like saying, oh, great, what will we do with these people? There's going to be so many of them, right? So I don't have the answers, and I think that's important to know and to provide some guidance, about how to manage them. But as far as the primary care would go, that's quite a ways off. But what we were thinking of is like, can we identify at-risk populations? So maybe it's a combination of their blood count parameters, trajectory over time. Maybe they have comorbid diseases combined with their age. Maybe there's germline factors. So you can imagine maybe there's some kind of combination risk that can be looked at, where you might pilot, screening for CHIP and interventions. But I mean, I'm really interested in this, and I don't know what the best way to go about it is. And if, we're definitely not ready to look in primary care. But that said, if there was an intervention, you imagine, how radical, a successful intervention, how radical a change that could make to hematology practice. And, I'm talking as a lab physician about reaching out into the primary community, but maybe also hand in hand with that would be hematologists, advising like primary care or family doctors, for example, or, so I don't know. I mean, I wonder if others have any thoughts too. Right now, there's not a lot of guidance, and we do need to know more about the natural history and more precisely about risk and about who is not at high risk. And of course, there'll be personal choice. We're not at that stage now, but whether people would want to be engaged and proactive in their health or would rather not know this type of information.
There's probably several ethical issues involved also. So, thank you.
Any more questions? So I think we'll wrap up. I'd like to once again thank Michael for his generosity and in accepting and giving us this lecture and sharing his knowledge about CHIP. It was a great lecture, and it was a pleasure to have you, Michael. Thank you very much.
Yeah, it's my pleasure. It's really been enjoyable to present this to you and to discuss these aspects with you. And I hope we can continue the discussion and And our collaborations are very exciting. And if any of you have any questions or ideas, obviously I've been open to collaboration, and I really would look forward to the day that we can, I can return and visit you in person. So thank you very much. Be well. And take care.
Thank you.
Take care.